Well, it's now gone 10 o'clock. So I think we should probably make a start because we've got quite a lot to get through today. And I think today's webinar is really, it's more a discussion group. So we're going to be asking for lots of input from all of you. As you know, we're kind of at this phase in Chorus where all our projects are moving from the needs assessment to the co-design phase. So we've been thinking how to make sure we really kind of capture this process and do this process as thoroughly as we can, and that we record what we're doing and try to do it in a really thoughtful and reflective way to make sure that we come up with health systems interventions that have the maximum impact and are also likely to be sustainable and deliverable within current systems. So this is a tall order. We all know from our needs assessments how complex urban health systems are. So trying to come up with interventions that can work in this complex environment with multiple stakeholders, multiple challenges, is really difficult. And I think if we can draw on theories, approaches, techniques to help us through this, that's going to make our work a lot better quality and a lot more likely to succeed. So that was really the idea with this webinar, just to share some approaches from the literature, but also to hear from you on your plans for co-design, really a brief feedback. So if just one person from each partner can be thinking about how to, we've got 5 minutes for you just to talk very informally about your ideas around co-design and your plans around the co-design process. So we'll come to that. Hopefully I'll just put that in the
sorry, that's okay.
Yeah. So hopefully I've just managed. That's fine. I've just put the structure into the chat so you can see what the plan is. So I'm just going to do a brief overview with lots of references for you to follow up, and we can share the papers as actual papers if that's easier than trying to download them. So we'll make sure that you kind of have access to all of the frameworks and approaches that we're going to discuss if you're not familiar with them. So I'll do a sort of 15-minute talk through of those. We'll have a bit of time for some questions. And then the next thing is just 5 minutes from each partner, really informal. You don't need slides, just talk us through your plans around co-design and any progress that you've already made. And then after that, we're going to go into breakout rooms by project one. So your project one teams together in a breakout room. So we'll have 4 breakout rooms for you to talk through a framework that we've put together with a bit of input from the EC. But I have to say, I feel like we really need to talk about it more as a team, because I feel people haven't really had the time to go through it. So basically, I'm going to share a document with you that we're proposing as a way to support your team to plan the co-design process and to document it at the same time. And this is partly out of my own learning on the job of like going through these co-design processes and realizing that you may not have documented the process clearly enough, and then attempting to write it up afterwards. And I think being able to document what we're doing as we go along the process is really useful for reflection, but also for writing up when we get to the point of writing papers. So I will share a document with you that has some sort of headings that are basically there to guide us through that thinking. So we'll have discussion about that in breakout rooms, and then we'll have time for everybody to feedback on that template and make any revisions, and then hopefully we can just all start using it in our projects. So that's the plan of today. Does that sound all right to everyone? Everyone okay? And if so, I will start to share my slides. Brilliant. Okay, hopefully you can all see that okay. So as you know, you guys have been busy doing your stage 1 and your stage 2 in the chorus project stages. So all that needs assessment work that you've been doing and is still ongoing for many partners, with the health facility assessments, all the qualitative work, all the participatory social mapping, transect walks, to really understand what's going on in the communities where we're working. And in addition to that, all the analysis of existing data. I know a lot of you've been looking at routine health service data, at DHS data, STEPS data, as well as the literature reviews and policy reviews that have been happening, and of course our systematic review. So those are stage 1 and stage 2 that we've all been working on over the last year or so. So coming into stage 3, this is really about the co-creation of the health systems interventions. So what are we actually what are these interventions? We need to very clearly kind of go through a process of drawing on all the information from stage 1 and stage 2, but also pulling in all the key stakeholders to come up with a really deliverable, feasible, appropriate and sustainable health systems intervention. Before we get on to stage 4 and stage 5 around implementation and evaluation. So that's the basic chorus project stages and where we're at. So the first framework I wanted to share is one, and many of you may be familiar with this. So there are quite a lot of frameworks that talk about intervention development and how to do it. And I've just picked this one, mainly because I find it quite straightforward, and it kind of fits as well with our chorus stages. So it's called the 6 steps in quality intervention development. And just to say that a lot of these intervention development frameworks really focus on very kind of tight interventions that are often around individual behavior change. So public health interventions that really, so it might be something on stopping smoking, or trying to increase the uptake of immunizations, or quite sort of focused. So they don't often focus on broader health systems interventions. So that's a word of caution with any of these kind of frameworks that we look at. But the 6 squared basically takes us through these 6 processes of defining and understanding the problem and its causes. Sounds familiar? Sounds like our stage 1 and stage 2 of chorus. And then a process of really clarifying which causal or contextual factors are malleable, so can be changed. Where are we actually going to have the most impact if we try and change something? What should we focus on? And this is all about trying to make sure that the intervention you come up with is really going to make a difference, and you're not expending a lot of energy on something that really can't be changed. And then step 3 as well. Okay, we've identified the bits we can change in the system. How do we actually do that? What are the mechanisms? What is actually going to take us from the current situation to the outcome we want? What are these mechanisms of change? And how, so stage 4 then is how are we actually going to deliver that in practice? What are the actions? that we need to follow to deliver those change mechanisms. And then 5 and 6 are a lot like the chorus stages that we had, stage 4 and 5, around really starting to implement on a small scale maybe, and then trying to collect evidence around feasibility, and then eventually evidence of effectiveness to judge success. So at the moment, we are really focusing on 2, 3, and 4 in our kind of co-design phase. So in a way, it looks straightforward, nice linear process. You just do all these things, your interventions there and will work. But are we really clear on the problems and the causes? How do we know which factors are really malleable or can be changed? And then how do we know what are the actions that are actually going to bring about that change, and how do we deliver those in practice? So we have to talk to all the different stakeholders, get all their input, but who in particular? And this is the real challenge. You can get a lot of people in one room and you'll come up with a million ideas, and trying to keep that focused and keep the, how do you deal with tensions? People will have very different viewpoints on what should be done. How do you deal with those? And then obviously there are people who won't engage with that process, or aren't able to engage in that process, and we can't hear their voices. We need to draw on the evidence, and hopefully our stage 1 and our stage 2 are really going to help us in chorus with that. But are there gaps? Are there other things we really need to know? And what do we do when the evidence doesn't necessarily agree with what people are saying to us in our meetings? So I wanted to share another approach, which is called experience-based co-design. So this is one way of trying to hear voices from multiple stakeholders to inform this process of co-design. And there's a link there to a YouTube video where they talk through the process. So when we share the slides, do have a look at that. It's really interesting. It's something that's been used in the UK to develop patient care pathways, and to try and improve patient care. But basically what they do is a whole process of talking to different stakeholders and interviewing them using videos, and then sharing those videos with the other groups. So everybody gets to voice their opinion, everybody gets to hear each other's opinions, and basing on that, you can then start to develop the co-design. So it's just a way of facilitating multiple voices to be heard. So it's an interesting approach, and something that some of you might think could be a useful way, using videos basically to capture the viewpoints of stakeholder groups that you may struggle to get involved in the stakeholder engagement process during co-design. So that's one thing. I think like with those stakeholders, obviously we've got all this information from our needs assessments, and that's going to really help us thinking through what are the root causes of the problem. And it might be there are some very superficial ones, but digging down to actually what is it within the health system that's going wrong. And we might say, well, there's just not enough community health volunteers, or there's not enough community health workers. But why is that? Really dig down within the health system. Is that because is it a recruitment issue? Is it because they're not remunerated properly to be incentivized to work in those complex neighborhoods? Is it because they're not being supervised? Is it because it's a lack of priority, a political issue? So really digging down, what are the root causes of the challenges that you're seeing? And I'm sure lots of you have seen these kind of problem trees, but it's exactly the sort of exercise you can do with your different stakeholders picking on the things that have come up from your needs assessment as problems, and to understand. And I think the interesting thing with problem trees is when you do them with different stakeholder groups, because they may well come up with very different root causes, and that in itself can be really telling. So it's about thinking through how do you use this method? Which groups do you use it with? How do you compare and contrast what they're coming up with? So again, just an idea to feed into your thinking on co-design. So then you remember in the 6 squid, the point about really identifying, what within the health system can actually be changed. And lots of different methods for doing this. And in previous studies, we've done trying to kind of really hone down an intervention, get it very, very clear. We've asked stakeholders to rank different aspects of the intervention in terms of which they think is, now it could be something like the most acceptable to staff, most likely to reach the urban poor, most feasible within the system, or the cost, potential for scale up. There could be different criteria that your team think are most important. And you can ask stakeholders to rank on the basis of that. You may want your stakeholders to use something like force field analysis, thinking of facilitators and barriers. Or there's a very useful paper where, which I'll share the link in a minute, the Resilient Asian Cities project, where they've gone through a whole process with different urban stakeholders to understand the system, they are focusing on health, but they do look at kind of cross different sectors, and they took stakeholders through a whole process of identifying where the system was frozen, where there might be energy for change, where there are examples of things working that could be scaled up, and where you can get kind of ripple effects and of things changing. So that's a useful paper that we'll share as well. So once you've kind of worked out, well, what are the root causes of the problem, which bits of the health system can we actually change, then it's about thinking about, okay, we've got our intervention, it's coming clearer, we know where we're going to focus. So then it's thinking about, actually, what does this look like within the health system, and how is what we're proposing going to lead to the outcomes we want? So there are a number of different frameworks out there to help think through the different aspects of a health system that could be included in the kind of change process. So there's the Consolidated Framework for Implementation Research, which has different domains that help us think through not only about the intervention and the characteristics of the intervention, but how it fits within the kind of wider context. So they call that the outer setting, and it sits within the institution, how it sits with the individuals that have to be involved with the health system's intervention, and the process of making it happen. So that's one framework that you might consider in terms of thinking through all aspects of your health system's intervention that need to be addressed. And then, so there's a few other papers that we'll share, which really talk about how you develop a theory of change, bringing in all your different stakeholders, and how this process, so in this example here from De Book, which is all about water and sanitation, they talk about how they sort of draft the theory of change, and then get different stakeholders to improve the theory of change, and then they peer review it. So they go through this whole process to really get clear their theory of change for their health systems intervention. And there is some really nice examples in that paper of the theory of change that they come up with. and how the intervention leads to more intermediate outcomes and then longer term outcomes. So this is an example of a kind of blank theory of change that you could use as a template. This is the implementation research logic model from a paper by Proctor, which is used really widely to kind of clarify the theory of change around your health system, around your intervention. But again, yeah, stressing not necessarily on your the wider health systems one. So I think with all of these existing frameworks, we need to think, is it really capturing the health system? So you'll see that this one, the domains here, they're actually the same domains as the CFIR, which I just showed earlier, around the outer setting and the inner setting, things around the intervention, the people involved in delivering the intervention, and the process that you go through. So this is one model that you could use. So you're really thinking through, okay, for you know, what are the sort of aspects of the health systems intervention that would go, you know, how would you clearly specify in each of these boxes here under the determinants? And then how are they actually going to be implemented? And what is it that is going to make this change happen? What are the mechanisms that mean that these implementation strategies will lead to these outcomes? And they recommend that you identify outcomes around implementation. So that could be things like change in knowledge of health providers about following training, and their kind of improved skill to deliver something, or it could be areas around kind of uptake of the intervention, or service outcomes, could be areas around uptake of particular interventions within the service, and clinical patient outcomes, then you're much more your health outcomes that you might be looking at. So reductions in obesity, or increase in immunization uptake, or whatever the actual health outcomes might be. So it's a useful framework to kind of get your thinking straight. And again, it's something you can do with your stakeholders. So it's a shared exercise. So they're really on board and help you identify particularly what these implementation strategies will be. So to give an example, for some of you I know worked on the TB and tobacco project, and some of the key implementation strategies were things around changing recording and reporting forms, training health workers, and changing supervision practices, were key kind of implementation strategies to really make the intervention happen. So it's a useful framework, but I think one critique of that is that it's very linear and may not capture the complexity of health systems. So I also wanted to flag the more kind of systems thinking approach that can help to take us to make sure that anything that's sort of that clearly laid out in a linear process is actually based on an understanding of the complexity within the health system. So I know the Ghana team, the Cornus Ghana team, have used some elements of causal loop diagram building with different stakeholders. And this is really a way of thinking through how different interventions and different actions sort of lead to other actions, and whether all the things that might happen help to reinforce in a positive way, or whether they lead to kind of more unintended consequences. So doing this kind of analysis really helps to identify the most effective changes within the health system and helps us to avoid some of the unintended consequences. And there's a really nice example of this being used in practice in this paper by Pomeroy Stevens, which is all about the Asian Resilient Cities project, where they talk through how they use some of these causal loop diagrams with different stakeholders to understand some of the sort of causes and effects, but also sort of based on that understanding how to take that learning to understand health systems, how health systems might change positively or negatively with different strategies being implemented. So it's an approach that you can use in workshops with stakeholders to think through the positive and negative potential of different aspects of your health system's intervention. So this information can then really inform your theory of change. So there's a lot of there's kind of a lot of technical, like they have specific use of language within the causal loop diagram approaches, and they talk about reinforcing cycles and balancing cycles, and also negative cycles. So reinforcing is where, you know, it leads to there's feedback loops that keep on making things more positive and your outcomes stronger, but where you have some kind of negative unintended consequences, that can disrupt that and become either balancing or negative. So that's a very good approach for thinking through the complexity. So those are the references. We've got a short moment for any questions, but really, I just really encourage you to have a look at some of these papers and these approaches and to see how they might be used in your co-design plans. So any questions from that very speedy whistle-stop tour of different approaches